Dr. Harshvardhan is here. So,
Good morning. I'm presenting a case that is presented with ball-eyed bilateral internuclear ophthalmoplegia after mild traumatic brain injury.
Please stick to the time.
No financial disclosures.
Yeah, please stick to the time.
Yeah, ball-eyed bilateral internuclear ophthalmoplegia. It's a rare neuro-ophthalmological disorder which is characterized by bilateral exotropia in primary gaze, bilateral internuclear ophthalmoplegia, impaired convergence, and can be associated with vertical gaze palsies, upbeat nystagmus, and skew deviation. So this is a case of 7-year-old female child with a history of mild head trauma subsequent to a post-epileptic fall, which is followed by unconsciousness for 15 days. Past history, she is a known case of hypoxic ischemic encephalopathy, seizure disorder, and intellectual disability. She had a normal ocular alignment and motility pre-trauma as documented by the photographs and the videos which were obtained from the parents of the child. Coming to the examination, patient was conscious but disoriented and uncooperative to the examination. On systemic examination, the CNS, there were signs of intellectual regression, that is inability to respond to the coherent commands, as well as severe weakness, which is associated with inability to perform the gross and fine motor weakness. She was unable to maintain the neck hold. There was bilateral exotropia present and bilateral convergence failure, and also in addition there was left eye ptosis. Vision she was not able to tell, but yeah, she was following to the lights. Pupils were 5 mm in the right eye, 4 mm in the left eye, and isochoria was present and it was sluggishly reacting. The lens was clear, both eyes. The rest anterior segment was within normal limit. Right eye fundus examination, there was temporal disc pallor, and in the left eye it was a complete disc pallor, and the rest periphery was normal. Investigations, MRI brain with MRI time of flight and venography. It showed a large intracranial bleed in the left parieto-temporal region, a decompensated communicating hydrocephalus, and foci of signal alteration in the midbrains and bilateral thalami, which is suggestive of subacute to chronic lacunar infarcts. The EEG done showed presence of multifocal sharp waves with absent sleep markers, which was suggestive of diffuse encephalopathy of non-specific cause. This is the MRI. This is showing, especially in this one, foci of blooming on SWI sequence, which is suggestive of the intracranial bleed, and also foci of signal alteration in the midbrain and bilateral thalami here, which is suggestive of subacute to chronic lacunar infarcts. So a diagnosis of Webinar syndrome with severe locomotor and neurological deficit secondary to mild traumatic brain injury was formed. On follow-up, the mainstay of management was observation along with symptomatic rehabilitation, and on follow-up, the convergence has been improved. The eye has been slightly coming to the primary position. Coming to the discussion, it is Webinar syndrome. It is characterized by bilateral medial longitudinal fasciculus damage with bilateral INO. The most common etiology being the infarctions of the midbrain in the older patients and the demyelinating disease in younger patients. And other associated etiologies can be traumatic, neoplastic, infective, etc. Thank you.
So what was unusual or rare about your case?
We can't be very sure that intracranial bleed exactly at that time trauma was responsible for INO, because the infarcts in the bilateral thalami, they are subacute to chronic, so we can't say that it is just because of the trauma itself. It may be because she has been a case of seizure disorder. It might have triggered it, we can say that, but we can't be sure that it is because per se of the trauma itself.
Is there any way that you can prove what is the etiology for your case, in your case? So in other words, that are there case reports of similar trauma leading to the start of Webinar syndrome?
We can exclude the other causes most probably.
Okay.
We can go ahead with excluding, for example, excluding the demyelinating causes or the infective causes. We can narrow down our etiology, possible.
Okay.
okay, thank you.
All right.
Thank you.
Usually the audience don't ask questions, but if you like, you can ask because we have some time.
If you have, we have time. So if you have some point to make or any.
long-term outcome?
So long-term outcome actually did,
Fast electrophysiological test, why you have not done that?
I said it was not done actually. The patient, after sustaining the mild trauma, after undergoing a conservative treatment, she actually had a bout of fever, etc. She had to get admitted. So the rest follow-up and other investigations were not done. And so it also depends upon the etiology. For example, if demyelinating, it has been reported that like 20 to 40% there can be a spontaneous resolution, especially it's a remission type of MS. And in infective, if the infection or the cause of infection is controlled, it can be corrected. In neoplastic, it has been shown that it is not so much, the spontaneous recovery is not so much possible in the neoplastic one. This is the one that I have actually studied or seen, not the post-traumatic. She has been improving. The bilateral exotropia has been improved. She has been fixating. The convergence has been improved, and rest follow-up is